We'll go ahead and get started. So, welcome everybody to tonight's very first Rehab Roundtable. Tonight, we're going to be talking about accessibility and PM&R. We're so glad y'all can join us this evening and take a chance on this new thing that we're doing in AOCPMR. So, I think this will be a great opportunity to come together and talk about different ideas and hear from some great medical student presenters who worked hard on their respective presentations. And before we get into that, I'd like to introduce our moderating physician, Dr. Nick Elwert. Dr. Elwert, we're lucky enough to have him as our vice president for AOCPMR, and he's also the liaison for the student council. This is just one of many things he does that he focuses on for collaboration and mentorship. He is wears many hats. So he's also the Associate Program Director of the University of Kentucky PM&R Residency Program, professor in the Department of PM&R at the University of Kentucky, and also the Medical Director of the Stroke Rehabilitation Unit at the Cardinal Hill Rehabilitation Hospital. He completed his medical degree at Lincoln Memorial University, DeVos College of Osteopathic Medicine, where he also earned a master's in anatomical sciences and completed his pre-doctoral fellowship in OMM and anatomy. His clinical passions include neurorehabilitation, spasticity management, and advancing diversity, inclusivity, and networking in PM&R. So with that being said, Dr. Elwert brings incredible expertise and leadership to tonight's discussion. So I will hand it over to him to introduce himself further in this event.
Awesome. Good evening, everyone. Thanks for joining us. Rhoda, I'm really just honored by the introduction. Now everyone can wake up and just snore through that. It's like, oh, but hey, so I'm so excited to be here. I'm gonna kind of consider this a little bit of like a hidden curriculum, especially in medical school. And sometimes throughout residency as well. You really start to see what our patients that end up having disabilities and accessibility issues, some of the struggles that they encounter in life. And so I don't want to take any of the glory from our presenters because they have some amazing lectures for you guys. I'm going to help provide some real world examples and some of the things that based on their papers that I see in my clinic being a stroke rehab doctor. But this is going to be a really awesome lecture and really awesome discussion. We really encourage you to, once the presentation has been done, ask questions. If there isn't any, then I'll probably speak up. But we really look forward to this to just being a collaborative effort and see what some of our patients have to struggle with on a day-to-day basis. So with that, I'm going to turn it over to the presenters.
Okay, guys, we had no specific order, but whoever wants to go first can definitely do that.
I don't mind going first.
Okay, that works. Thank you so much, Taylor.
Okay, yeah. So let me just share my screen. Okay. All right. I hope you guys can see my screen and hear me okay?
Yep.
All right. Okay. So hi, everybody. My name is Taylor Nakashima. I'm OMS 3 at Alabama College of Osteopathic Medicine. And today I want to present to you my article. It's titled Barriers and Facilitators for Increased Accessibility to Quality Rehabilitation Services in Low and Middle Income Countries, a systematic review. All right, so just kind of going over the background a little bit. The World Health Organization estimates that globally there's about 2.4 billion people who have some kind of health condition where rehab can benefit them. And this number is going to continue to rise just with people living longer. And this in turn will increase the prevalence in a number of chronic diseases and disabilities in the population. So this is going to continue to build a higher demand for rehab. And we're seeing that about 50% of patients in low and middle income countries do not get the rehab services that they need. Some example that they talked about was Zambia. This was a article published in 2015 where they show that about 17% out of this 47% that needed rehab did not get it. Another one was in Tonga in 2018. Their study came out with 20%. received rehab out of the 28% of the population that needed rehab. And there's many things, many barriers that kind of hindered them from accessing these services. Insurance being one of them. And we'll kind of get into the barriers a little bit in the next few slides, but just to get an idea, in the U.S., the National Health Interview Survey for the uninsured in 2024 revealed that there was about the uninsured rate for all ages estimated to be about 8.2%, which equates to about 27.1 million people. So that kind of can give you an idea of how many people are probably not getting the rehab that they need, even in a developed country like the US. So for this reason, the World Health Organization Rehabilitation 2030 initiative was created just kind of to emphasize the need for expanding these services and delivering them. And this last bullet point here, the International Society of Physical and Rehabilitation Medicine. This is a non-governmental organization that works with the WHO through its committees. And I just put that on there just to be more familiar with them, because they are the ones that conducted this systematic review to figure out what's been helping or hindering the expansion of rehab services in low and middle income countries. So here, this is the objectives that were talked about in this article. One was to explore the barriers, like I said, that make it hard to access these rehab services in low and middle income countries, to identify the facilitators that can help improve the access and delivery of quality rehab services, and deliver some or offer some suggestions to enhance these services in these low class or low and middle income countries based on the current data that we have. So here, just to go over a little bit about how the study was conducted. I'm sorry. So they received the relevant studies about. I'm sorry. Yeah, they received relevant studies based on these three primary databases: the PubMed, the WOS, and the Cochrane database. Out of these three primary databases, they collected about 150 articles, and then they reviewed and then excluded 108 articles, and that left them with 42 articles for the study. Some of the exclusion criteria included articles that did not use English as the language for this article, and they also excluded any other general medical conditions, such as leprosy, suicidal conditions, cost effectiveness of surgery, and other topics that were not really relevant to this discussion. And here kind of just shows you what kind of things were talked about in these 42 articles. On the right-hand side, it just kind of lists the types of studies that were included here. So just to talk about a few of the type of rehab, that's more talking about the top type of organizations that regulated these rehab services. So it was like things like, was it governmental? Was it government regulated? Was it run by the university, academia, or any kind of private companies? The discipline-specific associations, that's to the left of the top one. That is more talking about what kind of rehab services that they provided. Like it was talking about physiotherapists, occupational therapy, pulmonary or cardiovascular rehabilitation. Funding was a big one, education, social and cultural influences, leadership and policies, health insurance schemes, financial resources. Again, finance was a big one here, and patient experience. And here we have the list of barriers on the left-hand side and the facilitators on the right-hand side. We're going to go a little bit deeper into the key barriers on the next slide here, but just to name a few, finance, that was the most common factor for preventing establishment and regulating rehab facilities amongst most countries. Excuse me. Facilities and logistics that will include things like transportation, getting people from the rural areas to more of the cities where the rehab centers are probably located. So transportation was a big barrier to being able to reach the rehab services and also getting proper quality rehab standards. And education, you know, that one is a big one that they talked about too. This not only includes training programs to facilitate the amount of healthcare professionals being able to run the facilities, but also knowledge amongst the general public, just to be more aware of what rehab can offer, what are the limitations of um, um, low functioning and whatnot. Resources, also another big one, but more importantly, the most challenging, not having enough mobility aids or the assistive equipment like walkers, wheelchairs, electric beds, and whatnot. Those types of things kind of go ahead and kind of go in hand with finance. Um, and we'll kind of talk a little bit more about that in the next slide. Leadership and policy, so like government involvement, technology advancement, advanced treatment, community-based rehabilitation, social and cultural support, political and clinical, and then registries and standards. That last one is more like having guidelines and establishing a universal standard for quality rehab services. And on the right hand side, I won't get in too deep into it just because I have a slide for that. Just for the sake of time, I'll just move forward here into the key barriers. So these three were the key barriers to most of the countries, starting with rehab team. Most hospitals offering rehabilitation services lacked the essential teams, including rehabilitation physicians and allied health staff. So not having the regulatory bodies enabled or hindered the ability to have oversight to proper standards of care in rehab. And finance was another one. This one, again, was the most common factor preventing establishment and regulating rehab facilities amongst most countries. Obviously, high cost of services is going to be a big barrier, especially in those low and middle class income countries, and lack of government support. Not having the government funding for this population is going to be a huge setback and a barrier to providing these services amongst the low income communities within those countries, and then lack of insurance to mitigate those high costs of services, and then lastly, resources, most challenging. This kind of ties in with the two things above. Creating these health facilities is going to be a challenge. Most facilities will be started off by a non-government organization. They usually are the ones that kind of set the foundation in hopes to pass it on to a local authority. And then that local authority needs to be able to implement that in their health system hierarchy in order for the government to fund and manage those facilities. So that requires a rehab team. It requires financing. So that kind of all ties in together. And of course, transportation again. There was one example where they talked about a country in South India where there was a government managed rehab center, but that gave free services to the population, but there was only one, and that was located at the Capitol. So, you know, anybody that outside of if you're not close to the city, you're going to have issues transporting there. And rehab is not something that is one and done. It's more, it's a long-term treatment. It requires many days, sometimes back to back for a week or so. So if you don't have that transportation, they're going to have some challenges getting the rehab services that they need. And poor communication. It's kind of this is kind of a vague thing here. It includes the communication and data integration between government agencies, non-government organizations, and community-based rehab, and talking with each other to either spread awareness, educate the population about what rehab can offer, the spreading awareness about what limitations in functioning is, and there seems to be a poor perceived quality of rehab services. I remember talking a article that they pulled from where a physician in India was talking about how rehabilitation in India is a very the concept of rehabilitation is kind of a taboo thing. It's being done here and there, but on a very low scale. So you know, if the government is not also aware of it, they're not going to have they're not going to put attention, and then that will in turn, you know, hinder the funding and the progression towards creating health facilities and whatnot. So now we kind of go into the next slide here, talking about the facilitators and some of the examples that we've seen in other countries. So first, starting off with the National Health Insurance Plan, Bangladesh is working on establishing a universal health coverage program to try to fund for rehab services through the government and also through non-government support. Funding from government, which kind of ties in with the next thing listed here, funding from the government, non-government orgs. In Pakistan, the government is the government has things established so that they are providing disability allowance and medical compensation for government employees, new education and training programs. So again, most programs are set up usually by a foreign non-governmental organization that have the ultimate goal of handing it to local authorities. And I'm going to give you some example once I reach to the outreach programs here, but the next one is the telehealth services.
We have about 1.5 minutes left.
Okay, I'll kind of rush through. I think I have like one more slide. But anyways, yeah, telehealth services has helped like the Philippines improve awareness for rehabilitation in rural areas, outreach programs, for example, advancement of Rowan Rehabilitation Project funded by the United States Agency for International Development was implemented in Rwanda, where they had the goals of training, giving more training for PT and increasing awareness amongst the general public and healthcare professionals in order to reach, or in order to enhance and promote the referrals to rehabilitations in these kind of countries. And then social support, that's like, you know, self-help groups, volunteers for non-governmental organizations, and then the health information system, which provides an established shared terminology to collect more data, integrated, and inform the government so they know what kind of disabilities are out there, what the prevalence is, and what kind of support that they need for the population. And this is the conclusion. Sorry, I'm kind of going over the time, but the national policies is something that we really need to implement supportive policies and figure out the logistics and transportation services and stuff like that. Education, more opportunities for training to pump out more healthcare professionals, research, and awareness for the policymakers and the public. Government, obviously, we're going to need government support to organize everything here to facilitate a better structured healthcare system, and then the national registry and clinical guidelines to establish a universal standard so everybody can kind of follow a proper standard of care in rehab. And this is my references here. So thank you guys for listening. That was the end of my presentation. There you go.
Really well done. Just so we keep track on time, I'll be a real quick on a comment. So, Dr. Nakashima mentioned that, several different countries and areas that are struggling with different issues with accessibility to healthcare, et cetera. This is happening in our backyard. It is not uncommon for me to have to talk to a patient. Being a stroke doctor, I manage a lot of blood pressure, and I have to have a discussion with the patient of how much their medications are going to be because they got to put food on the table. And so that's going to influence the medications that I am going to start because, right, if I prescribe a medicine and the patient doesn't have the financial means to be able to afford that medication long term, I'm kind of doing them a disservice because I'm going to get their blood pressure controlled and then they're going to, have to make that choice. And most people are going to choose, well, I'm going to feed my family, not take my blood pressure pills. And then that may end up with another stroke or some other, right, medical issues. And so a lot of institutions have different resources and programs in place, for example, like scholarships for patients to go from an acute care level hospital to a rehab hospital, and then finding different types of equipments. So I know one example I can provide you at University of Kentucky is what's called HDI CATS. So it is essentially where individuals will donate used DME, and people can go in there and get the DME that they need that is no longer being used by someone else. And so that's where if someone comes over on a scholarship to our rehab hospital, we're looking at different opportunities to get them equipment. Also, the scholarship will pay for stuff. And so I love how this lecture was first because this sheds light onto the issues that we struggle with really worldwide. And then we're going to get more into some of the specifics talking about therapy and transportation needs that our patients struggle with.
Thank you so much, Taylor and Dr. Elwert, for that insight. It's great, really great to hear about that, comparing different countries and also tying that back to what Dr. Elwert said. So, Rebecca or Purvee, which one of you would like to go next?
I can go if that's okay.
Okay,
Awesome.
perfect.
Sorry, can everyone see the screen now? Awesome. Okay. So hi everyone, my name is student Dr. Purvee Patel, and I am a second-year student at Texas College of Osteopathic Medicine in Fort Worth. And today I'll be presenting on the article entitled Accessible Autonomous Transportation and Services, Design Considerations from the Perspective of Consumers and Providers. All right, so just a little bit of background here. So what exactly is an autonomous vehicle? So AVs are partially self-operating vehicles that are designed to help meet the transport needs of those who have disabilities. In the US, we have about 61 million persons with disabilities, with about 22.5 million reporting that they have travel limitations due to their disability. Inaccessible transport really hinders persons with disabilities access to essential services such as their healthcare appointments and getting to their places of work. Persons with disabilities also face higher unemployment rates and lower workforce participation than their other societal counterparts. And then, so prior to the study actually being conducted, they conducted a couple of focus groups just to get insights from persons with disabilities and also older adults. And both of the groups shared similar concerns about cost, safety, design, infrastructure, liability, and user communication systems of autonomous vehicles. In terms of rationale, what's the reason to do a study like this? So prior research has already taken a look at lack of accessible transit, challenges with the reliability of autonomous vehicles, lack of emergency protocols for these vehicles, inconsistencies with scheduling and communication, as well as difficulty finding seats and getting seated in these forms of transport. Hence, there is a need for a national survey to understand the needs and concerns of not only those who are using these vehicles, but also those who are creating them. And that's what this study aims to do. So in terms of methods, they designed 2 separate surveys that they disseminated to their target audiences. So one survey was called VOC, Voice of the Consumer, and that one targeted persons with disabilities and older adults. Some of the inclusion criteria were to be a person with disability who needs to use transport at least once or twice a week. And they also could have included any partners or caregivers that assist with that transportation. They also included older adults above the age of 65 with and without disability. And then for the VOP, or Voice of Provider survey, that was targeted for those who design, operate, and sell accessible transportation. And their only inclusion criteria was that they had to have at least 1 year of experience in the field. The exclusion criteria for both categories of people were those who did not answer key survey questions about their roles, their type of disability in the VOC, or their experience with disability in transportation. Next, I wanted to talk a little bit about how the surveys were constructed. More so, they were constructed as multiple choice questions and a 5-point Likert scale. However, there were some spaces for open-ended comments for participants to voice their opinions. And then there were 3 general categories discussed by both the VOC and the VOP, and that was autonomous vehicle services, as well as automated features and accessibility features. Still on the methods, I wanted to talk a little bit about how they administered this survey and also the recruitment for it. So administration was done electronically, and the IRB was approved by University of Pittsburgh, which is where a lot of the researchers from the study came from. Participants were given an option to complete the survey either online or on the phone. So they had multiple options there. And then in terms of recruitment, I really like that they use both digital and in person. So digital, they use emails and sent it to advisory board members as well as advocacy organizations. And I thought it was really unique as well that they sent them to individual university disability resource centers. In person, they did more so person-to-person referrals, spreading the word. They also attended conferences, medical conferences across this nation to spread word about this survey. And they also visited individual independent living centers to gain more of the opinions of our elder individuals. So talking a little bit about data analysis and clustering. So without getting into too many of the specifics, the Voice of Consumer study aimed to ensure a representative sample by comparing their statistics to national benchmarks. And then in terms of cluster analysis, the autonomous vehicle related questions in the survey underwent a 2-step cluster analysis that basically grouped the answers into 2 clusters. And this was primarily done based off of demographic variables that we'll be discussing in another slide or 2. Significant data was pushed to the top of tables, whereas non-primary responses or non-significant responses were pushed to the bottom of the table and primarily blanked out so that that didn't clutter up any of the data representation. Further, the validation of the clusters was analyzed with the silhouette score, which I will also discuss in this next slide. So in terms of results, the survey participation was very, very good for the Voice of Consumer survey. They had about 1,160 participants, and around 900 of them met the inclusion criteria, which is a pretty good number. However, for the Voice of Provider survey, there weren't nearly as many participants, and even then, fewer who met the inclusion criteria. However, the good news is that even amongst that 45, it was a fairly even split of opinions from vendors, experts, and designers, which is very good to hear. There was a pretty good geographic representation across the US with participants from 47 of our states. Primarily, they had responses from Pennsylvania, New Jersey, Illinois, and California. And then I wanted to talk a little bit about the cluster design and findings. So cluster 1 ended up being primarily a group of individuals who were ambulatory challenged, and cluster 2 was more so of older adults without disability. And interestingly enough, cluster 1 had a lot of similar opinions as a couple of other groups, and those include those who are visually impaired, those who live independently with some difficulties in transportation, as well as those who live in rural settings. Cluster 2, on the other hand, identified more so with the responses of those who have cognitive disabilities. And as I mentioned in the previous slide, a silhouette score, I had to look it up, but it basically helps determine cluster validity and how well the clusters were made. They got a score of 0.3 to 0.4, which is fair to good, but ideally it would have been 0.7. So we'll talk about that in the limitations section as well. A couple of key demographics were age, income, and community setting, and these were shown to heavily influence how the clusters were formed. Alrighty, so I wanted to talk a little bit about how each cluster fared in the survey questions. So cluster 1 heavily emphasized the desire to use autonomous vehicles to access leisure activities, entertainment, shopping, and self-care. They also prioritized personal vehicles or individual vehicles over public transport. They had a not really too big a preference on what exactly those vehicles connected to in terms of transport, and they desired a wider range of automated features. This includes self-drive, self-parking, veering data, etc. And they also had a preference for better created user profiles, storage capacity, and wheelchair accessibility. Cluster 2 had a heavy emphasis on reaching medical appointments. They didn't really have a preference for what vehicle type they wanted, but their main emphasis was to make sure that those vehicles got them to the airport. They also desired all automated features. Interestingly enough, they didn't have much of a preference towards accessible entrance locations, but they did have a big preference for grab bars and handholds, which we know our elderly population prefers for safety reasons. There were some areas of agreement between the two clusters, and those were highly prioritizing accessing their medical appointments, preferring modern tech-based scheduling methods, for example, using apps or websites to schedule use of autonomous vehicles, and the importance of getting to the airport. So a couple of additional notes here. Since there wasn't that much data on the Voice of Providers survey, there wasn't too much to work with there, but it was made known that the providers differed on their focus of what was important to them. So vendors, for example, desire to focus on using minibuses, whereas the experts who designed them preferred using vans, cars, and light rail for their own personal reasons. Designers and experts prioritize phone app development, whereas those who actually create and implement the services prioritize kiosks and physical transportation centers. So a little bit about the discussion here. There were two categories. So they wanted to talk about how does this information inform the design of autonomous vehicles and the development of autonomous vehicles. So in terms of design, there's a big consensus from provider and consumer on making sure there were easy to use interfaces for booking these autonomous vehicles. They also wanted to make sure there are customizable service options and different vehicle formats that could be widely accessible. And they also really heavily emphasized on the Voice of Consumer survey that there's flexible scheduling and routing. In terms of development, the two most important points is that there's an inclusive vehicle design, as well as robust testing with different user groups. So this means not just those with older age, not just those who are visually impaired, not just those who are wheelchair users, but all of them and even more diverse groups. A couple of the conclusions were that participant preferences for AV services were heavily shaped by their type of disability, their age, and their income level. I think it's key to note that insights from this study can help policymakers at the state and national level create more effective standards for accessible vehicles and for autonomous vehicles, because that's gaining a lot of traction in the US, and it could be a potential form of transport for a lot of us in the future. A couple of limitations about this study are, of course, the missing data from the Voice of Provider group. This not only affects the reliability of the findings, but also the generalizability of the study on their part. Cluster analysis always has its challenges. You're not sure, did you make enough clusters? Did you make too few or too many? And that is always subject to personal bias. There was some recruitment and instrument bias that was found. And of course, there's always call for future research for any gaps that were found in the data. In this case, that would be more so on the part of the Voice of the Provider. And then here, I just wanted to include a little slide talking about what's currently out there in terms of autonomous vehicles, particularly in the US, as that's where the study was conducted. And some of the current user-friendly apps ranked by those with disabilities are Uber WAV, Uber ATG, Lyft Access, and Wheelie. And then two of the many models that are being piloted out there are Waymo and Cruise. Waymo is Google-based, and they seem to have a little bit more of an edge in making sure that their vehicles are accessible. They include ramps, wheelchair accessibility, and accommodations for assistive devices, whereas Cruise is a little bit more generalized and just said that they have more spacious areas and flat floors, which really could mean a couple of things. But I think it's interesting for us as students and providers to take a look out there to see what's available for patients, especially if they don't have any type of social support to help them get to not only their appointments, but activities of daily living. And something that was emphasized and is a gap in this research and a lot of the research out there is implementing emergency response systems in these vehicles and also adaptive safety protocols. So that's something that definitely further research could emphasize and work upon. And that concludes my presentation. Thank you all for listening, and please let me know any question, comments, or concerns.
Really well done, Dr. Patel. Any questions, guys? One thing I will, so kind of correlating with the last the lecture is, right, one of the biggest barriers to rehab is transportation. I cannot tell you the number of patients that have had to call and just miss my appointments because they're unable to get transportation. Their transportation fell through. This is a huge deal. And, you know, getting a wheelchair accessible van that someone has at their disposal is much easier said than done. You know, there are different companies that can modify cars to make them more accessible, but that costs money and it costs time. And, you know, this is something that, you know, I would go out on a limb and say all 35 of us that are on this call probably used our car today. And it's not that easy for someone that is in a wheelchair or having some type of accessibility concerns. And so, you know, I implore you all to, wherever you're at, wherever you're doing your rotations or plan to do your rotations, see what local transportation system is out there, figure out what different ways you can help patients. Typically there, you know, there can certainly be more than one. And so if someone is unpleased with the transportation service that they're being provided, see if there's another option out there. But you know, getting, you know, we talk about access to healthcare, you got to get there first. And so this was a really huge topic, Dr. Patel, to bring up a very significant issue in our healthcare and those that have issues with mobility.
Yes, very good job. Alrighty, our last but not least, Rebecca, thank you so much.
Hi, everyone. Okay, let me go ahead and share my screen. All right, one second. Okay. Can you guys see that okay? Okay, perfect. So hi everyone, my name is Rebecca Riekki. I am a second year at Nova Southeastern in Fort Lauderdale. And first I just wanted to thank Rhoda and Dr. Elwert for having me today. Also, big shout out to my AOCPMR physician mentor, Dr. Mamsang, for being here. and I am presenting on the utilization and potential disparities in access to physical therapy for spine pain in the long-term care population. So some background knowledge about the topic. So spine pain is the main disability globally, and it's a main source of healthcare spending in the US. And it is a well-established treatment modality with physical therapy being a non-pharmacological treatment. And in fact, PT reduces the overall healthcare costs for the treatment of spine pain because it reduces the need for more expensive treatment modalities like surgery, imaging, and opioids. And the occurrence of spine pain increases with age, and back pain is the most common MSK complaint amongst older adults living in long-term care LTC facilities. So many LTC nursing homes are also skilled nursing facilities or SNFs, and they provide Medicare Part A fee-for-service rehabilitation for short-term post-acute residents. And this patient population is particularly vulnerable as there are several challenges when accessing quality health care. So whether that's insufficient caregiver support or if they have cognitive impairments, the LTC residents are a particularly vulnerable population. Medicare also has some outpatient Part B benefits for these residents that do not require a patient referral for physical therapy. So I wanted to briefly touch on some of the Medicare plans that are out there. So Original Medicare is the fee-for-service plan that includes hospital insurance, which is Part A, and medical insurance, which is Part B, and Part D, which covers prescription medications and certain vaccines, can also be added in the Original Medicare plan. And Medicare Advantage is the alternative plan where private health insurance companies provide the services. So that includes both Part A, B, and usually D for this plan. So continuing on with some more background information, even though there could be a removal of patient referral requirements from the Medicare standpoint, there still may be some underutilization of physical therapy services for long-term care patients with spine pain due to several factors, including cognitive impairments, low PT staff in a SNF facility, providers' views on patients benefiting from physical therapy. So these are just some factors that could point to some underutilization of the PT services. And sometimes the PT services in the nursing homes actually focus on overall function rather than addressing pain or quality of life that could be impacting the patient as well. And patients who are socioeconomically disadvantaged or part of a minoritized racial and ethnic group receive less guided concordant care like physical therapy services specifically for spine pain. And this could be to different environmental and community resource influences. So these are just some guiding questions. If we get to it at the end, if you guys want to just like keep them in mind as I go through the rest of my presentation. So if there are any interventions that could be implemented in the long-term care facilities to improve equitable access to PT services. Secondly, should we consider prioritizing a long-term care patient's spine pain versus addressing their daily functioning when it comes to tailoring their physical therapy treatment? And lastly, what potentially the role of policy changes like reimbursement rates could play in addressing PT accessibility inequities. So just going into the study objectives and design. So the primary thing they were looking at was to assess the use of physical therapy for spine pain in long-term care residents. Secondarily, they wanted to investigate possible differences in physical therapy access based on demographics and socioeconomic factors. So there were a few studies that looked at the PT utilization and the inequities of PT accessibility for this long-term care patient population with a history of spine pain. So that was the reason for their study objectives. And they used a secondary cross-sectional analysis of Medicare administrative data looking at the long-term care residents who were 65 years and older who had a fee-for-service Medicare plan. So going into some of the methods, they used Medicare carrier files and fee-for-service claims from 2016 to 2019 for Medicare beneficiaries 65 and older with spine pain diagnoses. And these fee-for-service claims included inpatient, outpatient, and SNFs. And they use an established algorithm to further identify long-term care residents from January 2017 to December of 2019. And the receival of PT services were determined by a claim with a PT evaluation, current procedural terminology or CPT code during a time in a long-term care facility. So they also were identifying if a PT episode was specifically for spine pain. So if the main diagnosis on the evaluation claim matched any of the ICD codes for spine pain diagnoses, then that's when they would determine the PT care was tailored towards spine pain. And then they also used a multivariable logistic regression to approximate the odds of receiving PT care while taking into account which demographic, clinical, and community factors played a major role. So this just outlines from the study the inclusion and exclusion criteria that they used. So I mentioned earlier that they used an established algorithm from a study conducted in July of 2010, and the algorithm used Medicare claims data to classify nursing facility stays and differentiate between short from long-term care. So this inclusion criteria figure was based off of that algorithm. And just some of the exclusion criteria included long-term care residents who were not continuously enrolled in Medicare Parts A and Part B in the 12 months before their index date of becoming a long-term care resident. And they also excluded long-term care patients without at least one spine pain related healthcare claim prior to their long-term care index date. And you could see here kind of the final cohort of patients that fit their inclusion criteria. And then this just outlines some of the features and descriptive features of the study group. So I'm just going to highlight a few things from the table. So 35.7% were male. So the majority of the patients used for the data were actually female. 88% were of white ethnicity. 76.4% lived in an urban residence. 70.6% had either multiple spine pain regions or an unspecified spine pain region for their complaint. And then out of all the total cohort, roughly half received some type of physical therapy as a long-term care resident. And then this just outlines the results of the regressional analysis that they concluded. And I'm going to go into more depth on the next page. So going over the results of the study, so even though roughly half of the long-term care patients receive physical therapy care, only 12.1% of those services targeted spine pain. And spine pain also wasn't the most common primary diagnosis claim that was tied to the physical therapy services. So actually generalized weakness and impaired mobility were the most common diagnoses. And they found that the majority of the PT care was active treatment. So active treatment just includes therapeutic exercises or gait training, while passive treatment usually includes therapeutic modalities like hot packs, cold packs, ultrasound, or manual therapy. And then looking on the left, these were some of the factors that showed higher odds of patients receiving physical therapy. So white patients, patients who had dual Medicare and Medicaid eligibility, if they had a concurrent inpatient admission, if they had multiple spine or unspecified regions, they're more likely to receive physical therapy. some of these comorbidities listed, and then if they lived in a non-urban zip code. So in the study, they identified large rural, small rural, isolated rural residencies. So those rural zip codes usually had a higher odds of receiving physical therapy. And then lower odds of receiving physical therapy factors included older age, male, non-white, racial, and ethnic groups, if they were medically complex patients, if they had certain cognitive impairments like dementia, or depression and mood disorders, or they came from a disadvantaged urban zip code. And the majority of these odd ratios had statistically significant 95% confidence intervals. And yeah, go to the next slide. So in talking about some of the factors that contributed to factors that patients were receiving higher odds of physical therapy, the location and maybe amount of spine regions that were affected with pain severity seems to play a role in accessing those PT services. And with the higher odds of patients who had a concurrent inpatient admission, having a higher odd of receiving care could demonstrate an inpatient resource exposure or influence to having access to physicians, for example, who will give referrals for PT services. And then there's evidence that non-long-term care settings have decreased access to PT, or they have like low staff rates in rural areas. However, this study found that patients from a rural area or who were dually eligible for Medicare and Medicaid were more likely to receive PT services. However, the study noted that the claims lacked facility level data like staffing. So it's kind of hard to tell if there's other factors within urban facilities that could have impacted the results. And it's also unclear if urban facilities prioritize PT services for short-term patients versus long-term care residents. And going into some of the other factors contributing to lower odds of receiving physical therapy, it seems that facilities prioritize maybe addressing mobility issues versus addressing their spine pain. And in essence, this could be because of the staff at these facilities wanting to reduce physical lifting requirements of these residents. And so by working on those issues instead of their spine pain, it reduces the physical lifting of the staff. And also the medically complex patients, it's important to note that the medical stability of a patient could influence the role of starting physical therapy. And that could also tie into older patients not being less likely to receive physical therapy because these patients tend to have multiple conditions. And so the physicians might underuse physical therapy if they don't think it'll be beneficial for the patient. Additionally, there's evidence that patients with cognitive and mood disorders can benefit from physical therapy, but this study found that patients with these comorbidities actually receive less physical therapy services. And so it could point to its underutilization specifically for these patients. And then the lower odds of receiving physical therapy in non-white racial and ethnic groups is consistent with prior literature on these minoritized groups having reduced access to and receiving lower quality care. So some of the strengths and limitations of the study. So first, the study looked at patient services as it relates to spine pain, and they were also looking at the long-term care patient population and disparities among this. And so they also had a large sample size, and that was one of the pros. Some of the cons was the retrospective design of the study kind of could not, you couldn't look at causation with the factors that were looked at, and some of the Medicare data was limited in looking at some of the outcomes of these patients. Okay, sorry, I'm gonna rush, almost done. So the conclusion of the study, so they mainly found that spine pain, physical therapy tailored treatment was actually low in long-term care patients, and that there are possible disparities in access to PT care for long-term care patients with a history of spine pain. And this was particularly found among those in non-white racial and ethnic groups, or those in disadvantaged urban areas. So future research could potentially examine the outcomes of physical therapy for this population, and they should account for these inequities when looking at these services. And finally, so the certain demographics and socioeconomic factors may hinder a long-term care patient's access to PT services. So we said the minoritized racial and ethnic groups, and the inequities in PT utilization for long-term care residents with spine pain. This was seen between patients of different medical complexities, or if they had different spine regions. So there were disparities in access to PT in that regard. And addressing these barriers and disparities could ultimately enhance care quality and health outcomes for this patient population. And especially with the interprofessional dynamic of the field of PM&R, it necessitates strong communication and teamwork, especially with the physical therapists aiding in their recovery. And so I had mentioned earlier that the PT is the main non-pharmacological treatment for spine pain, and it helps reduce the overall healthcare cost. So by tackling these issues in patient and PT accessibility, physiatrists will have a decreased need for prescribing or utilizing they wouldn't need for more expensive treatments and treatment modalities like surgery or opioids. So it's important that they address these issues, because there are also different benefits to PT, even if it's not geared towards spine pain in this patient population. Okay. Sorry, I know I am over time, so we probably won't get to these, but these are my references. Thank you.
Really well done. Any questions as we kind of close up for the evening?
Yes, I have a question. That's okay.
Yeah.
Hi, Dr. Elwert. So I was curious, talking about accessibility and kind of the theme of the talks that we covered so far, what initiatives have you seen in your program as far as uh, opportunities for residents to engage in community or policy advocacy to strive towards that goal of accessibility? I mean, outreach is quite often a recurring theme that I see in this area, like working with local organizations or urban planning initiatives. I would love to hear you speak on that and what you would like to see to continue this mission.
Yeah, absolutely. I kind of want to take your question one step further. I think all three of our lectures really highlighted a lot of the issues that our patients face, and a lot of things, just a lot of issues that right now don't have a ton of answers. But the fact of the matter is we can be a part of that answer. And this is not intended to be like a rah speech, but I mean, we're talking about people's lives, right? People are unable to do things in their life, whether that is go to the doctor, go to the movies, basic things that we take advantage of. People aren't able to do that. And so, we can do that through being involved in different initiatives, which I'll address here in a second. Can also be as simple as, starting off with, getting the walker for someone that's getting ready for physical therapy, or taking someone's tray away from them. I always recommend, start small. Those are really simple things that someone, may not be able to do anymore, especially if they're in a hospital setting, but something that you can help them in their quality of life. Because at the end of the day, that's what, right, as PM&R docs, we are helping with the quality of life. And so some of the initiatives specifically that you were wondering about, I'll speak about here at the University of Kentucky more kind of throughout the university, is the one that I mentioned called HDI CATS. So this is a It's essentially a superstore for DME equipment that gets donated. So if someone is not using their equipment anymore, or if someone has additional equipment, or if someone has equipment that they're just not going to use, instead of donating it maybe somewhere, they will go and just give it to this place, donate it free of charge, and then different individuals can come and get that free of charge so that they can also have access needs. Also, and we are certainly not the only university that does this, but different scholarships, like I mentioned, also financial assistance that can be from the university. So I know I see a couple of patients that utilize those resources so that they can get the care that they particularly need. For us, from a resident focus standpoint, one thing that we love to do is actually going out and teaching our community, specifically our students, about medicine and about the things that we do in PM&R and about some of the issues that we see. So we go to some of the local high schools, talk about what we do as physiatrists, and just be able to, again, shed light. Because I think that's one of the biggest things, Dr. Nakashima's paper talking about, hey, these are the issues. You have to shed light on the issues before you find the answers to the issues. And so lots of different opportunities that I know our residents are involved in, and also residents, across the nation, a lot of awesome initiatives, and also organizationally. So through AOCPMR, through the Rob Gottman Leadership Grant, there's been some awesome things that have been done to increase accessibility in the community. And there's also other organizations that you can advocate from a governmental standpoint as a student and a resident.
Fantastic. Thank you.
Yeah.
All right, I know it's 8 o'clock, so if nobody has any additional questions, you're free to go. But if you do, you're welcome to ask now. I do want to thank everybody for joining us tonight for this important discussion. I know accessibility is a large scope within our field, so just picking a few topics to talk about was really awesome. And I want to thank Taylor, Purvee, and Rebecca, and of course, Dr. Elwert, for your incredible contributions and insights. This was really great, and really appreciate everyone's engagement and everybody who participated. So thank you guys so much for being a part of this and being passionate about, inclusivity and accessibility. Have a great evening, and we look forward to future events. I'll also put links to the next 2 Journal Club signups in the chat if y'all would like to sign up for those now, but they will also be on our social media.
And I see one question in the chat. If it's okay with you, Rhoda, I'm happy to stay
absolutely.
on. And if someone has questions, I'm more than happy to stay on. So one question that is in the chat by Jackson: how do PM&R teams collaborate with occupational therapists, physical therapists, and other specialties to address accessibility needs for patients? I think that is a great question. So, I will say collaboration is definitely easier within the same medical system. So the physical therapists that and occupational therapists that are working at UK, and some of the other docs that I work with at UK, it is very easy to collaborate. So whether that is making sure that they have the resources, or just that they know of the resources that are that are available, and within the system, within where you're at. Then the other aspect is if someone is in a rural area. So here in Lexington at UK, we serve a pretty rural population, and patients may have not seen their doctor for years. And again, resources are very limited, and they complete their therapy at home. One time here recently, I actually just called the therapist on the phone with the patient in the room, and we talked about what we were doing, what resources were available. Sometimes it's just as easy as picking up the phone and talking. And that medical system, you are playing a role in that patient's care. It might be different, and you have to figure out what resources are available. So it really is as easy sometimes as picking up the phone. Now, the answer to the problem may not be as easy as that, but start off with a conversation, because you start to put more heads and brains into a problem together. You can start really benefiting our patients.
Hi, Dr. Elwert. I have a quick question. And so my article kind of talked about, lightly touched about telehealth medicine.
Mhm.
I know that's becoming a big thing. Is there anything in PM&R where telehealth can be kind of helpful other than just spreading the awareness of of the rehab services?
Yeah, I've actually started to utilize telehealth a lot more than I expected, especially as a
No.
resident, now as an attending. And so, one thing that I have been utilizing telehealth a lot for has been responses to medications and responses to injections. So, for example, botulinum toxin injections. As opposed to making someone drive 3.5 hours back one way for maybe a 10-minute exam by myself, and then they have to drive another 3.5 hours back. I will do a telehealth with them, and we'll talk about, hey, how did you respond? Do we need to make changes? And then they're able to show me from an exam standpoint what their spasticity looks like. And I'm able to save patients, maybe it could be 7 hours of travel just through a telehealth visit. Another thing I also like to do is if I feel as though, there are some times where people get lost in the system and get lost in healthcare. I also, I want to make sure that I'm staying on top of things, and, someone doesn't have to wait 3 months or longer to follow up with me to see how they responded to a medication adjustment. And so I will use telehealth that way. And we'll get on a quick telehealth call and say, hey, how did you respond to this? Or is good, bad, indifferent? And then we can make medication adjustments that way. And so yeah, I've actually started to use telehealth a lot more here recently. It's a little tough to do new patient visits, especially from a stroke rehab standpoint. But for follow-ups and responses to different interventions, I've definitely used it a lot, and it's been pretty well received, because it's saving patients. We're still also able to further care as well.
Awesome, thank you.
Yeah.
And also, I have another question. I'm sorry, I got one more.
Yeah.
So in terms of insurance, this includes Medicare, Medicaid. I know patients can uh, be covered in different ways depending on the state you're at. And
Mhm.
have you seen um, any any insight in that, where one state has more access? Well, if you live in one state, they have more access to PM&R services rather than another, just because federal insurance can cover that. I'm just kind of thinking about this as I'm trying to uh, think about where I want to go to residency, where I want to eventually practice at. I know insurance can be a big problem for patients to get the rehab that they need, but if
Yeah.
federal things like Medicaid, Medicare can cover those things in that particular state, they're more likely to obtain those, and for us to be able to actually help them and not be limited by those kind of things.
Yeah, absolutely. I think that's a really good question. So, I kind of mentioned at the beginning of tonight's talk of a hidden curriculum almost. I feel like insurance and what patients can get based upon where they live and what type of insurance that they actually have, I think is I think it's a huge part. Here I try to incorporate all of that in our discussions. So whether that is from, hey, insurance won't cover this medication, but let's talk about other medications that the insurance will cover. Or in other words, hey, insurance will not cover for home health therapies after a patient is discharged. So what do we need to do to put our heads together to figure out how this patient's to continue to improve after their recovery? What kind of home exercise program can we provide them? What kind of instructional materials? What I would advise you to do is, as you start to rotate at other places and start to get to know other places, see what type of, ask the residents and ask the faculty, hey, how do you incorporate this aspect? Because it is a really important part of medicine that I don't think gets talked about enough, in all honesty. Now it is always changing, it feels like. And so once I understand one thing, I feel like 4 curveballs come at me. But different programs do it different ways, but it is definitely a key part. I know that's not really a specific answer, just because each state is different. And so that's what I would do, is start asking the residents and attendings at different programs of, hey, how do you incorporate this? Or how did you learn? Just asking other people, hey, how did you learn about how insurance does this, this, and this would be a good way to start figuring out, hey, where you might want to, consider that part of your residency. But you're going to see all different types of insurances in residency.
Thank you.
Yeah.
All right, well, if nobody else has any questions, then everybody's free to go. I really do appreciate everybody for taking the time. I know there was a lot of work put into these presentations and coming out today. Now, this was a new thing for everybody, so we really appreciate it. And big thank you to Dr. Elwert for trusting us and trusting this process. So we really appreciate it. I think it ended up being a really great discussion and a lot of good points that are relevant to all of us.
Absolutely. Well done, guys.
Thank you so much. We'll post this recording for everybody to share with anybody. And yeah, anybody can reach out to me if they have any questions or feedback or anything like that. We'd love to hear it. And also definitely get involved with AOCPMR if you can. It's a great experience.
Thank you.
So
Bye, everyone.
everybody have.
Thank you, guys.
Thank you, Dr. Elwert.
Have a good night, guys.
Thank you.